Idiopathic orbital inflammation, orbital pseudotumors. Idiopathic tumor-like orbital inflammation composed of a pleomorphic inflammatory cellular response and a fibrovascular tissue reaction. Orbital pseudotumors are idiopathic, affecting children and adults. They could be unilateral or bilateral. Onset can be acute, subacute, or chronic. Acute: explosive onset, pain, muscle paresis, visual loss, proptosis, conjunctival chemosis, injection over insertion of muscles. Chronic cases are rock hard, can mimic serous carcinoma. Gross picture: inflammatory signs with inflammation sharply delimited by orbital septum. Types classified by structures involved. Myositis: tendons are thick in 50% of cases. Diplopia and pain on ocular movement are present. Periscleritis: epibulbar, tendon, and orbital fat. Perineuritis: dura of optic nerve and orbital fat. Dacryoadenitis: swollen oblong lacrimal gland, orbital and palpebral lobe. Trochleitis, vasculitis, idiopathic sclerosing inflammation. Primary chronic immunologically mediated fibrosis, showing poor response to steroids and radiation. Visual disability is present. Wall-to-wall radiodense mass involving muscles, optic nerve, and globe. Microscopic picture: edema and cellular polymorphic infiltrate composed of inflammatory cells, lymphocytes, plasma cells, histiocytes, and eosinophils. Lymphoid follicles with germinal centers. Absence of atypia. Evidence of inflammation: perivascular lymphocytic cuffing, diaparesis, not vasculitis. Concentric fibrous lamellae surround vessels, orbital fat involved. Heavy infiltration of orbital fat. Lipogranulomatous inflammation, involve muscle tendon, late fibrosis. Granulomas, eosinophils. Extensive fibrosis in sclerosing pseudotumor with late orbital fibrosis. The following factors differentiate orbital pseudotumors from lymphoid tumors. Pink, not blue. Hypocellular lesion with more cellular polymorphism, fibrosis, and inflammatory signs. Diffuse process with acute inflammatory signs. Exquisitely sensitive to corticosteroids. The following factors differentiate orbital pseudotumors from Graves' ophthalmopathy. Involvement of muscle tendons, presence of eosinophils. Thyroid ophthalmopathy or Graves' ophthalmopathy. This is an autoimmune inflammatory disorder that affects the extraocular muscles, the thyroid gland, and the skin. This is the most common cause of unilateral or bilateral ectophthalmos. Graves' ophthalmopathy can occur with hyperthyroidism in 90% of cases, euthyroid status in 6%, hypothyroid function in 1%, Hashimoto thyroiditis in 3%. 60% of hyperthyroidism develop ocular disease within first year of diagnosis. Smoking is a significant risk factor of Graves' ophthalmopathy. Forms. Mild forms are more common in females in early adulthood. Female to male ratio is 6:1. Severe forms are more common in elderly male, more than 50 years. Graves' ophthalmopathy is bilateral asymmetrical. There is autoimmune T lymphocyte imbalance, with increased percentage of suppressor to cytotoxic T lymphocytes. T cells are directed against thyroid follicular cells. B cells may produce anti-muscle antibodies. Target cells include pre-adipocyte fibroblasts and possibly myocytes. Hyperthyroidism is caused by elevated thyroid stimulating hormone receptor, stimulating immunoglobulins. Gross picture: axial proptosis is due to deposition of glycosaminoglycans mucopolysaccharides expressed from fibroblasts within orbit with secondary water retention. Adipogenesis, enlargement of extraocular muscle bellies by lymphocytic plasma cells and mast cells infiltrate. Inferior rectus, medial rectus, superior rectus, and levator complex. Enlarged muscles show foci of chronic non-granulomatous infiltration with lymphocytes, CD4 positive and CD8 positive, also focal aggregates of B cells. Muscles degenerate and become fibrotic. Inflammation spares tendon, meninges, and orbital fat. Pathology: upper eyelid retraction 75%, lid lag in down gaze 50%, dry eyes 30%, diplopia 17%, lacrimation and photophobia 20%. Complications of thyroid ophthalmopathy: visual loss 7.5% due to optic nerve compression at orbital apex and severe proptosis with exposure keratopathy. Differential diagnosis of inflammatory proptosis: infection, orbital cellulitis, cavernous sinus thrombosis; inflammation, orbital pseudotumor, orbital myositis, Wagner's granulomatosis; neoplasms, leukemia, Burkitt's lymphoma, rhabdomyosarcoma, retinoblastoma, metastatic carcinoma, Langerhans cell histiocytosis; endocrine dysfunction, dysthyroid exophthalmos.